there is basically mediated by the superior laryngeal nerve, recurrent laryngeal nerve. So everything that's at the larynx, at the vocal cord level, and slightly above. So, that reflex would stay present. The question about whether or not the overall experience to him would be one that he would find, like could he sleep through the night better with a tracheotomy? Would he find that would he find the experience of having the trach in more comfortable than what he does now? I don't know. The reflex will remain, but maybe he would not feel. Maybe his breathing would be so much more secure that maybe he wouldn't necessarily feel the urge to do that. I just don't know. I don't know. Placing a tracheotomy tube is not. I don't think that high of a risk of a thing to do. It's just that it's a little bit of an unknown whether or not it would solve, the issues for you. If he was having intractable recurring aspiration pneumonia, I'd say to you that would have to be your next logical step in order to try to get a hold of that. So that would be an easier question to answer. If his cough was just so ineffective that he had no way to clear secretions out of his airway, definitely tracheotomy is your better way to go. But I'm just not sure if it would solve the reflex action anymore, if that would just simply go away with the trach in.
The other aspect we were concerned about was just being able to ventilate him.
Yes, definitely a tracheotomy, and I think is a very easy way to ventilate him. You would simply hook the device up right to here and be able to get air effectively that way. And it might be superior to other devices placed over the nose of the mouth, because I think in this direction you might have a propensity to be blowing secretions down into the airway with positive pressure ventilation.
Yeah.
So you probably would not have that effect. You would not have that effect with a tracheotomy. A tracheotomy, so there's an element there of care and maintenance you have to do. The problems most people find with a tracheotomy is that the plate here, where the tracheotomy is going into the neck. So he's on Coumadin right now. Eliquis, yeah. Sorry. So there's a wound, there's a hole here, and so there's a propensity for some oozing. Normally, because of granulation tissue, a little bit more with the Eliquis. So bleeding from the area, we just have to kind of contend with from time to time. The plastic device, the plastic tube, if if their neck is somewhat forward and stays in that position during the day, they do have a tendency to cause an erosion where the plate will dig into the breastbone into like a pressure ulcer.
Okay.
So that's kind of an issue we have to kind of contend with. The tubes have to be removed and replaced, periodically, usually probably every 3 months or so. Otherwise, you develop so much granulation tissue here at the site, it gets to be really bloody or foul smelling. But that's it. And then generally the tracheotomy tubes, we place them under general anesthesia, so he'd go to sleep for that. And if you have that done in a hospital, the nurses will kind of work with the family or caregivers to just kind of show them a little bit about how to care for a trach, how the different pieces of it, what they mean, how do you work with them. So.
But that would be the mechanics of that. He would stay here then in the ICU or in the hospital for a week or 2 weeks, and then I talked to an ALS patient who said she went to a step down facility.
Yeah.
Is it possible that so? I guess it depends on how he responds, determines how long he stays here.
It does, and it depends too. So right now he's at home with you guys?
Yeah.
So is the intention then that he will just come home?
If possible, yeah.
So people can come home with a tracheotomy tube. What you need at home is you need suction. And the issue about what kind of pressure support device or ventilator, the pulmonologist may be able to help with that. Is he on a CPAP or a BiPAP right now?
Yeah.
So then you would just simply, so that just needs to be worked out. So you can give pressure support through a tracheotomy tube, but you might need a different ventilator type device. Frankly, I'm not really sure. I don't know how adaptable a CPAP machine is to trach or not, but a pulmonologist could help us work that out. If the decision is that he's going to come home, then we just need family or caregivers trained in how to care for a tracheotomy, have suction, have supplies. It's identical to what you've got. And then that's kind of it. The issue about skilled nursing facility or long-term care tends to revolve more around the question of if family cannot take care of a patient and cannot meet the needs, then I would say, yeah, long-term care is necessary, SNF is necessary, or if there's going to be a plan for long-term ventilator. So let's say a person needs to have a ventilator machine either part of the day or 24 hours a day, and some of the ALS patients do, then the question is how is that going to be managed? Home ventilator, portable ventilator, or long-term nursing facility. Most people, for simple tracheotomy, they're probably in the hospital about maybe 3 days to 4 days. That's mostly for issues related to just training the family and the comfort of that. If they do need ventilatory support, then once the trach is done, they might go to the ICU for that, to use a ventilator. So that's a little bit about kind of how it works. Yeah.
And who makes the decision? So we can make the decision that we can bring him home as long as we can prove that we can take care of him.
Yeah. You guys seem to be doing just fine, and what you have here is all you really would need. The issue would really kind of evolve more around, I guess, can you continue to meet those needs, and then the ventilatory help that you would need afterwards. A CPAP is fairly easy to apply. Frankly, applying a machine to a tracheotomy tube, if you can do a CPAP or a BiPAP, you'll find hooking up to a trach tube is simple. That's just tube snaps on, you're good to go. So yeah, I think those are the things. Usually when a patient is in the hospital, the nursing staff, they make assessments of needs, how the teaching is going, what a patient needs. If something were to come up and it were somehow to be obvious that a patient is going to be too ill to go home, or the family's not going to be able to meet the needs, then there definitely has to be a discussion, or there would be a discussion. There would be arrangements for the patient to go to whatever facility they need to meet their needs. Another discussion that comes up, but I think it's fairly clear, is how aggressive a person wants to be, how aggressive a patient and the family wish to be. Some of our patients with ALS, for example, will want to have a tracheotomy. Others decide that that's not something that they want, that the impact on their quality of life is not going to be worth it, and therefore this is not going to happen. So, but I think you obviously have been making very good decisions all along. So, whatever your decision is, if it was tracheotomy, that's what we would do, and that's how we would kind of go about that. Yeah.
So when the tube gets changed, do we come here every 3 months to change it?
You can, and actually we teach patients and caregivers to do it at home. If a patient is otherwise fully ambulatory but needs a tracheotomy tube for some reason, like let's just say airway scarring, not to make it sound like it's a simple thing, but we teach patients to change them at home. You just take it out of the neck, put in a new tube. So it's not something that's technically very, so complicated like an aortic balloon pump or something that can't be done. I mean, these people, you can live your entire life with a tracheotomy tube. And the changing is something that we can do here, and patients can do at home. It's not a terribly technically challenging or horrible thing. So that's definitely a doable, livable task. The changing of the tube is just to maintain cleanliness, maintain hygiene, and the balloon parts themselves, or the tube parts themselves, get a little bit broken down in the presence of secretion. So you want a fresh tube from time to time.
In a patient like that, where you've done a trach, what complications have you had that they've had to go to a skilled facility? Yeah,
so sometimes the issue is if you have them, sometimes they're very weak after anesthesia, and they can have a very hard time recovering, and it can be you know, it can, even though the cases themselves are relatively fast to do, sometimes people coming off of a ventilator can be hard. And I don't know why that is. Sometimes, you know, just kind of being a little bit weakened for a while to have a general anesthetic is enough to kind of tilt things over. And sometimes patients may need, that might be the event that they're now on a ventilator. Not always and not commonly, but that can be probably the worst thing, is that now they're going to leave on the ventilator. They can get a pneumonia, they can aspirate, because they're high-risk patients to aspirate, and when they're hospitalized and if they're getting any pain medication or sedatives or things like that, oh my goodness, that's a risk for an aspiration. But having the trach in offsets that to some degree. Bleeding is pretty common from a fresh trach site, and folks that have to be on anticoagulants, it's a real issue. Some people we just simply cannot stop the drugs for any period of time. There's too high a risk for clotting, and then they can bleed fairly heavily from a neck wound, and there's not a lot we can do about it except pack it off and just give the neck wound time to heal. So bleeding is an issue. The worst, there are some risks of putting in a trach tube. When you do this, sometimes you can cause a pneumothorax, and a person needs a chest tube. That's not a light, high-risk complication, but its potential could happen. The risk of injuring a major important structure in the neck is not high. It's pretty low. Carotid artery or jugular vein, it's pretty low. So there are short-term risks of doing the procedure that are just not that high risk. There is an issue for folks that might have a tracheotomy tube in for a prolonged period of time, and that's a propensity for the tracheotomy tube to erode into the innominate artery. It's a risk for patients that are going to need to have a tracheotomy tube in the long term. It's called tracheoinnominate fistula. And the tube itself, by being in the airway, can actually erode through the trachea and into the innominate. And if that happens, frankly, that's generally lethal. So
What is the incidence of that?
what's the incidence of that? The incidence of that goes up the longer a trach tube has been in. It can happen, you know, sometimes you see it very, very, unfortunately, quickly, like in weeks or so, and sometimes you never see it at all. But the incidence in overall trach patients is actually probably low, like probably, you know, 1 or 2% of long-term tracheotomized patients, but it is usually a lethal complication. Mucus plugging or debris plugging up the tube and making it hard for a person to breathe happens as well. That's why you need to suction and keep it clean. So those are kind of the general ups and downs.
How would you see it played out for him?
So his situation is interesting. It's kind of interesting. Usually the indication for a tracheotomy at this point is recurring pneumonias or progressive respiratory failure that now the patient is going to need to be on a mechanical ventilator. That's usually the situation that we find ourselves. The issue about, you know, the secretions now in the airway and him coughing more, I don't know. It's an unknown. The pattern that you're in here, where he's being able to maintain his airway, and you obviously are suctioning pretty regularly and aggressively, and the Botox is probably keeping him in good shape. The question is how long would that go on for? How long could this go on for? And what's the impact on your guys' ability to give care? If you and he are up 24/7 and it's just becoming untenable, I could see that being an argument to do the tracheotomy and to hope that the tracheotomy would make things better. So, yeah.
And then, if you were to do the trach, so I guess you really can't say if you would anticipate you'd be able to bring him home, or because you don't know how he's going to respond to anesthesia.
So I'd venture to say the likelihood is that you'd be able to bring him home. And the reason why I say that is because he's off oxygen, he's breathing on his own, and he's got very attentive caregivers already in place. There are folks that, family will tell us, listen, we're simply not going to be in a position to care for mom or dad once a trach goes in. And so we already know, and they're not going to be able to live at home because the family's not going to be able to care for them. If you feel you have the resources at home, I suspect you can bring him home. I think you could bring him home. If he had a complication, if he had an event, pneumonia, inability to get off the ventilator, some other event, a stroke, through a PE, something like that, that could change our situation. But as you are now, with the equipment and the help you've got, and him breathing on his own and off oxygen, the chances are, if you wanted him home, you could probably bring him home. Yeah. If you felt, after we've talked and all, if you're feeling like things are going to be, that the situation would change with the presence of a tracheotomy, it would be good to know, because what we would do is we would just plan on the disposition being in a different direction rather than home right away, and help you start looking for places. Yeah.
Yeah, we want to bring home. Oh, we've got fantastic caregivers, and
Yeah.
we've got a lot of help at home. So
You're unusual, to be honest with you. You're unusual. Most people don't. But no, the way you guys are and the way he is now, the odds are is that, yeah, he would come home with you. Yeah. Yeah. The thing of it is that the grunting issue is him protecting his airway, and it is, I couldn't tell you, I don't know if that's gonna
yeah.
cease.
Yeah, if it's a reflex, I can understand that it might persist afterward. The other one is because, again, he doesn't have pneumonias that often, but it's really his ability to ventilate. And he's had episodes more of pause breathing, and the pauses have been longer. Now they're like up to a minute. And so, do you have any sense of he would need to be on a ventilator during the day? Probably. Because at night, likely he would need to be on a ventilator when he's sleeping. Yeah.
Yeah, a great question. With his gas normal, I don't know. I don't know. That's a really good question. And I'm sorry. His underlying, what exactly is his?
So it's kind of nebulous. So he was diagnosed with progressive supranuclear palsy. He had a neurologist that questioned that diagnosis because he's outlived the diagnosis, and so it's now just Parkinson's plus. And so it's just kind of this loose collection of symptoms. He has a lot of rigidity. But we haven't seen a neurologist since 2008. His neurologist moved away. He didn't have a suggestion for him, and so we've just been managing more pulmonary stuff instead of neurologic stuff.
Sure. I have to say, so certain situations, ALS, multisystem atrophy, I would say, we have a fairly more clear picture that, respiratory deterioration is going to happen. And usually you want to try to get the tracheotomy tube in folks before that happens. Parkinsonism, not a neurologist, but I can tell you, what's my 2 cents on taking care of folks over time? Probably aspiration is more likely the issue, as opposed to frank, just full-on respiratory failure for folks that have more like Parkinsonian syndromes. So I don't know if he might just be maybe he'd be totally off ventilator during the day completely, and for some time to come.
He's had a couple of episodes where, because he wears a pulse ox at night, for example, on Tuesday, he had an episode where he desaturated down to 68. And we put oxygen on him, we were suctioning, and I don't know how it cleared, but somehow it cleared. And his O2 popped up. And in those instances, and he's probably had 6 of those instances in the last 4 years.
And those are, and it doesn't look like those are like obstructing sleep apnea episodes. He's not asleep.
No, it's actually, some of them we've actually pulled out a mucus plug. Yeah. So, but it may be a combination of he's having an apneic event and the mucus is sitting at the right spot and it just occludes. And we suction, we can't pull it out, and it just starts to desaturate. But that's interesting you say the risk would be more aspiration than really pulmonary status for the Parkinson's patients.
That would be my impression, and so, you know, that's, for ALS, I would say, oh, certainly, you know, respiratory failure, and plus, of course, all of the other issues that go along with a lot, and inability to swallow, that goes hand in hand. But Parkinson's, maybe this is more of the trach serves more of an airway protective function, in which case, perhaps, you know, how long would a person survive? Maybe quite a while, if that issue is mitigated. So yeah.
I almost feel like we're kind of at the precipice where we need to make a decision now, because we've kind of been pushing the envelope with all these complementary non-invasive therapies. Yeah. So you would agree that we either do it now while he's in pretty good health, or just ride it out.
Yeah, I think you've got. I wouldn't say. I mean, I don't think like he's not in danger. I mean, I don't think he's in any imminent danger. Like the grunting, I'm not worried about at all. If it were bilateral vocal cord paralysis, I'd say you're in imminent danger. I think, you know, the issue I would say is just, you know, what's your time frame? I would probably think, I mean, you have time to decide. You have time to decide. You probably have, frankly, I think, probably would have even months to decide if you really needed it. But you probably, the issue is if truly the respiratory failure is becoming more of a concern, or you're finding that your Hague is not getting through the night, and you guys are up all night long to try to deal with the suctioning, you're probably reaching a point where you're you've exhausted this line of treatment, and probably you're going to want to go somewhere else, even with its attendant, you know, risks or issues. That's how I kind of look at it. You don't have to make that decision today, tomorrow, next week, next month, but you're probably maybe reaching a point where this strategy is just not going to be workable for the foreseeable future.
Yeah.
If one were to say, like, well, we're going to stay this course until forced to make a decision, I would probably think that kind of event, if something were going to force you, would likely be an aspiration pneumonia. So you might not necessarily want to wait for something like that. So, yeah.
I agree. I think if we got to that point, it would almost be too late.
Yeah. I guess I would have to say you do have a better perspective than I about how do you look at what has happened over time? Has this been, you know, going on over time? Is this going on over time? Has this, you know, is it going like this? And then what's the time bar? Are we talking about days, weeks, months, years? What's your perception? I generally tend to think that probably if this were months to years, you know, the trajectory is probably more like this. ALS is rapid multi-system atrophy, and it's get the tube in to stop the respiratory failure. If Parkinsonism and other things are more like this, so it's a good question. I would just, my only caveat would probably be that I would hope that the tracheotomy, if done, would alleviate any of the discomfort you guys are experiencing through his grunting, and maybe him being up at night. Maybe he'd be able to rest. Maybe.
And I think that would be our hope. That
Yeah.
he'd be better ventilated, so he'd get a better night's sleep. Yeah. Yeah. When we talked in 2011, but I think we're more comfortable with it, understanding the situation a little bit more.
If it's any consolation, his exam compared to 2011 is pretty much identical. He actually has a little less secretion than he had back then, but he's not deteriorated from the examination point of view. Like, and again, you know, we would look for other things, you know, no more cough reflex, no more ability to close the cords. If you look down into the trachea, all you'll see
A whole open tube.
a whole tube just awash in secretions, and he's not crossed those physical thresholds. So he's remained fairly stable since 2011, interestingly, by the exam. But so I don't know if that's reassuring or not. But
That is reassuring, very
Yeah.
reassuring, yeah.
so he seems to be. Your strategy has worked well to date. But it sounds like it's pretty labor intensive, you know, and stuff.
Lately it has been, but we have great care and we don't
Yeah.
think about the effort that it takes.
Mhm.
I think more so really just trying to make sure he's got a good quality of life.
Mm-hmm.
And knowing that he's having to work so hard. I don't know, and he's a little bit nonverbal, so I don't know if he has a lot of anxiety, and because of anxiety his triggering his grunting. I don't know if he has anxiety about his airway closing. I don't know if he could feel better because he's better ventilated. All those things I would think would be an offshoot of it. Before there were definitely some trips that he wanted to take that we wanted to be able to take him on. And we've traveled, and who knows, maybe we can still travel with an event, a trachea event.
You can. Yes,
Yeah.
you can. And a tracheotomy is, like, I would say, a universally recognized medical thing. It would probably simplify, frankly, traveling, because if you did have issues in another country, somewhere else, most medical facilities would readily be able to handle and work with a tracheotomy, as opposed to him not having one. Let's say he developed an aspiration pneumonia in a foreign country. Now he's intubated in a foreign country. Now what are we going to do? So I would say that, yeah, I think that there's probably some pluses there, because I do think it probably makes that aspect simpler to manage.
And I know this is not a fair question, but if it were your parents, what would be your boundaries for decision making?
You know, I don't know, but, well, I do know. I talk to my parents frequently, and my parents have expressed their wishes, you know, to me very clearly about, you know, end of life care, and, you know, their philosophy, their personal philosophy is maybe just a little bit different. They're very non-invasive, and so, and we've talked about this. My mom was in the medical field, and so, you know, they kind of have that kind of point of view. And everybody's different, though. But everybody's different, you know. Certainly, if there was a reversible condition, they absolutely want me to take care.
Yeah.
You know, they don't want me to just put them in the nursery, and they made that point. But you know, but other things, yeah, that just a different philosophy. Yeah.
I appreciate you being very sensitive to that. Thank you.
Sure, that's okay.
Yeah. So, okay. Anything else that if we were to, so we would talk about as a family. I have the sense that we would be moving toward that direction. How hard is it to get into your schedule? What days you operate?
So I operate kind of Monday, Wednesday, Friday. What you could do is, what I probably just do is, I'll let this is my surgery scheduler.
Okay.
I'll just let her know that you guys are considering that. I would just give her a call if you decided to proceed, and then she can kind of help you. I don't think it's a major issue to find time to do this. The operation itself is probably all told about an hour and a half, you know, to do everything. So it's not, I don't think it's that too difficult to execute that type of a procedure. So we book out it's the holidays hit us pretty hard, as I'm sure you probably have the same issues with the surgery and then the reduced OR times. But, you know, you can give her a call, we can try to find some time.
Okay.
Mhm.
Okay, that sounds great.
Mhm.
That sounds great. But that's surprising you said his secretion it was actually less in 2011, and he just had the Botox booster, so I would imagine in a couple of days it would be even less.
Yeah. I mean, I remember his exam vividly, and remembered how much thick secretion had been sitting in the airway, and then when he inhaled, saw
just
some of
went
this
down.
went right down.
Yeah.
And looking
Thank you
today.
for remembering that.
Oh yeah, I mean it's a very vivid picture. And then today, you know, I know that the secretions will vary from moment to moment and hour to hour, but yeah, I think you can see certainly no worse than what he was in 2011. Certainly, absolutely not. It looks a little better. So I guess the Botox probably does help. You know, probably does. Yeah.
It's made a huge difference.
Mhm.
a huge difference.
Yeah.
And actually, that was Dr. Good that suggested that.
Mhm. Yeah, that's good.
So,
Mhm.
great. Perfect. Well, thank you so very much, Dr. Damos. Really appreciate your
Sure,
time, putting
sure.
us into your schedule. You already had a full schedule.
No worries, no
Very,
problem.
very much appreciate it.
Yeah, you bet.
Yeah.
I'll stand by. Just maybe let me know your thoughts. You can also email me or call me, whichever's easy
Oh,
for
that
you.
would be wonderful. Thank
Yeah,
you very
so
much.
please do. You know,
Okay.
we have the. Do you use the Stanford?
Epic?
Yeah.
Yes, but it's strange. It's hard for me to get access to his chart.
Oh, how about?
Yeah.
Oh, I see. So you know what? Let me do this too. Let me just give you an alternative. My academic email. That's easier too. If you if you want to send me a message like that, what I can do is we can correspond with kind of a secure email feature. So if you just say, you know, I'd like to talk to you about my dad, or even his initials, what I'll do is I'll reply back to you with a secure thing, and then you can
Wow.
reply back on a secure line, and
Okay.
then you can talk to me in that fashion if you'd like.
Okay,
Yeah.
that would be great.
Sure.
Yeah, because I'm not a provider for him.
Yeah.
I can't always get access to his chart.
Sure, of course,
Yeah,
of
so,
course. Yeah, so you can't really get onto the My Health feature, right?
No,
Yeah,
not
so
for him.
not
Yeah.
for him. So
Yeah.
that way you can, and we can do that securely.
That would be great.
Yeah.
That would be great. Thank you so very much, Dr. Damos.
Anytime.
So much appreciate your expertise and your guidance.
Oh, my pleasure. I'm happy to
Yeah,
help. I'll help
yeah.
you any way I can.
Oh, you truly believe that. Thank you.
Oh, thank
Yeah.
you. Thank you.
Yeah.
All right, well, you guys have a good day, okay?
Yeah, thank you so much again.
Yeah, very welcome. My
Yeah.
pleasure. Thank you. Bye, Mr. Quo. I'll see you later. Good man.
Dad's got a good grip.
Yeah, good man. Good man. All right, you have a nice day. Nice to meet you. I want to see you again. I'm sorry. Thank you. Take care. Thanks for your help.
This is our caregiver,
Thank
Nadia.
you.
You did a great
Nice to
job,
meet you.
Nadia. Nice to meet you too. Thanks. You're a great. You keep up the good work. You're a great section person.
Not only me, there's other ones too. They're really good.
You all
Thank
have a good
you.
day, okay?
Thank you so much,
so much,
Dr.